Well, welcome everybody to the Family Medicine Grand Rounds for today, June 15th. Those of you who are interested in CME code activity, in CME activity, the activity code is listed there for you. You'll just need to text that code along with the word attend to the number listed before midnight tonight. But on the next slide here, I'll go over some other information specifically for those who are claiming credit. Next slide. So for those who have not yet registered, if you do have an account with the CME office here at UT, all you'll need to do is text your email address to the toll-free number listed there. After that, you should get a message stating that you have successfully registered. From there, you'll want to go ahead and for each session that you attend from that point forward, you just need to text attend and then the code for that date. Today's code is listed there for you. You'll want to make sure you do that again before midnight tonight. But if you have any questions, you can always reach out to me as well. Next slide. So as we get started here, we want to take a moment to remind everybody, if you could please just make sure that your microphone is muted. Also remain attentive and engaged in this session. And then also, if you do have questions, Dr. Wang has mentioned that you, if you have a pressing question, you will have to unmute and ask. Otherwise, if we put them in the chat box, we'll take care of those at the end of the session. I will also be putting in the evaluation link towards the end. I'll put that in the chat box if you could help us out with that. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds. We are partnered with the South Central Area AHAC, and our mission statement is there for you. Next slide. For those who are wanting to make sure that their attendance has been recorded with the CME office, you can visit their website there and take a look at your transcript. But if you have any questions, please feel free to reach out to me, or you can reach out to their office as well. Next slide. For those who are AAFP members, you'll need that transcript to submit in order to claim credit through the AAFP. If you do have questions, you have their number there, or you can reach out to me as well, and I'm happy to help. Next slide. We also do want to mention that it is our goal of our Grand Round series to make sure that we are addressing these nationally established physician core competencies that you see listed here. Next slide. And we also do need to mention that Dr. Wang has no financial relationships with any eligible companies to disclose. Next slide. So for us today, we have Dr. Emily Wang. She is going to be presenting to us what's in a pre-op eval, navigating the operative risk assessment. So I will let her get started.
Great. Thank you so much, Nicole, and really providing me the opportunity to talk with everyone about the preoperative evaluation. I'm one of the faculty in the Department of Medicine, hospital medicine. All my clinical time is at the VA, and I'm also one of our associate program directors for our internal medicine residency. And so preoperative risk assessment, perioperative care, and medicine consultation is a passion of mine. It's one of my areas of interest. And so I love really talking about this topic. So I thought I'd start off with this cartoon. I think it's very appropriate for the surgical realm, in addition to, honestly, COVID and what it's been doing to us over the past few years. So today's objectives are, we will identify the main components of our preoperative evaluation. And number two, utilize the main components to perform a preoperative evaluation. So we'll start off with the case. Our patient is a 64-year-old man with a history of an ALS-like disease and COPD needing surgery tomorrow for a C1-C2 fracture. The patient's functional status has declined since his last PCP appointment, and he is now needing assistance with some of his ADLs. Per his neurology clinic visit notes, he has dysphonia and aspiration related to his neurologic disease and has refused a recommended PEG placement at multiple visits. Your neurosurgical colleagues have asked for a pre-op evaluation. Your immediate response is A, he needs a TTE, a cardiac stress test, and PFTs before surgery. B, he needs an EKG, labs, and chest x-ray before surgery. And if those are normal, he is cleared for surgery. C, I will review his chart and see him to assess his risk for surgery. And D, he is cleared for surgery. And you're thinking, why am I getting called? He has a cervical neck fracture. You need to just take him to surgery already. All right. So when we think about a preoperative evaluation, and you get asked, can you clear the patient for surgery? So in general, I would say we do not necessarily, quote unquote, clear a patient for surgery. What our job is to do is to provide an assessment of risk and medical stability, recommend medical optimization, and assess for need for further workup. What we'll mostly cover today is, some of the topics for the pre-op evaluation, in addition to covering some of the tools and aids for these calculators that we can use, understanding that they're aids, not decision makers. So in the pre-op risk assessment, there are quite a few categories here, but some of them will go pretty quickly. And we generally think of cardiac, pulmonary, venous thromboembolism, anticoagulation management, delirium, diabetes, medication management, and special circumstances. So I think when we think about risk assessment, cardiac, I have bolded and underlined here, is initially what comes to mind. Understanding that I'm partly putting this in jest to make fun of our cardiology colleagues, and also to think about the fact that cardiac is just one of the risk areas we're assessing. But we will start off with cardiac first. So this is an algorithm for the perioperative cardiac risk assessment. This was taken from a recent JAMA article in 2020. And it is a algorithm that is relatively easy to follow. That's a combination of different guidelines and assessments, including the most recent 2014 ACC/AHA guidelines on pre-op risk evaluation. And so starting here at the top box, when the patient is presenting, and this is for non-cardiac surgeries, we assess if the patient has any cardiovascular risk factors, understanding that if the surgery is a low risk surgery like a cataract replacement, in general, those patients do not need an extensive pre-op evaluation. If the surgery is urgent and is needed in the next 6 to 24 hours, in general, we recommend the patient proceed to surgery. In this box here, when we're considering patient risk factor assessment, if the patient has any one of the following more urgent or concerning cardiac conditions, including cardiac arrhythmias, severe valvular heart disease, acute heart failure, and acute coronary syndrome, this is where we'll need to discuss with our cardiology colleagues, considering delaying surgery, and have a multidisciplinary discussion with cardiology, anesthesia, and surgery. If the patient also has a prior coronary stent, I would talk with our cardiology colleagues. And this is where we're going to focus a lot of our attention. This box, patient has a risk of preoperative major adverse cardiac event over or equal to 1%. And once we go down to these boxes below, this is where we'll calculate the major adverse cardiac event. And here we'll sort of talk about the patient, if they have a moderate or good functional capacity, then they don't actually need further workup and they can proceed to surgery. And then thinking about if the patient is not able to perform METs, then considering further testing and whether or not this will change our decision to go to surgery. So I would say for the cardiac risk assessment, there are a few calculators that we're most familiar with using. I believe everyone has maybe heard about or is most familiar with RCRI or RRCRI, which is the Revised Cardiac Risk Index. The ones that we more frequently use and educate our residents on is the MICA, or otherwise known as the Gupta Cardiac Risk Calculator. The American College of Surgeons, ACS and SQIP, also has their own surgical risk calculator. When we use these calculators, we need to be cognizant of the fact that they actually have differences in outcomes, which may explain some of the differences in the percentage risk you may have come up when you put it into the calculator. And so for RCRI, the revised cardiac risk, what they're looking at is myocardial infarction, cardiac arrest, complete heart block, in addition to pulmonary edema during admission and during the 30 days after surgery. When we look at the MICA or the ACS tools, looking at myocardial infarction and cardiac arrest within 30 days after surgery. So for the cardiac risk, the revised cardiac risk index, this was actually, it's been around for a while by Lee and colleagues in 1999. And this is based on 6 predictors, and the number of predictors will predict the rate of cardiac complication. So one of the 6 predictors is high risk surgery, including things like aortic, abdominal aortic revision surgery, high risk surgeries like large fluid shifts, surgeries over 3 hours. If your patient has ischemic heart disease, that's considered a predictor as well. History of congestive heart failure, history of a cerebrovascular disease, TIA, CVA, diabetes requiring insulin, and a preoperative serum creatinine of over 2. So depending on the number of the predictors the patient has, it will give you a rate of cardiac complication. So just to point out here, even if a patient does not have any of these predictors, the rate of cardiac complication is 0.4 to 0.5. As you go up in the number of risks that you have in the predictors, you'll have a higher rate of cardiac complications, all the way up to, if it's over 2, a 9 to 11% risk. When we look at the MICA or Gupta and the ACS and SQIP calculators, this is actually based on the American College of Surgeons National Surgery Quality Improvement Program, which is a database that our university and VA hospitals are part of. This database is international. It's over 600 to 700 hospitals now. And at each facility, there is a surgeon champion in addition to a nurse navigator that randomly selects patients to be placed into this database. So UH and our VA are part of this database. And when they're looking at these outcomes, they're looking at myocardial infarction, intraoperative and postoperative in the 30 days after surgery. And this is how they define an MI. ST elevation over 1 millimeter and 2 contiguous leads, a new left fonal branch block, a new Q wave, and elevated troponins 3 times the upper limit of normal. And then for cardiac arrest, it's the absence of cardiac rhythm resulting in a loss of consciousness, whether it's malignant VTAC, SVD, PEA, or asystole. So in this MICA Gupta risk study where they created, it was a development and validation of this risk calculator. When they looked at all comers for patients who are having non-cardiac surgery, 0.65% of the patients have MICA, myocardial infarction and cardiac arrest, within 30 days post-op. And then 61% of these patients pass away within 30 days post-op. This is the calculator, the Gupta risk calculator on QXMD. It's also on MD Calc. And so you can look it up in the cardiology section and do pre-op risk assessment. And it just requires 5 input data points: the age, creatinine over or equal to 1.5, ASA class, which is also known as the American Society of Anatomy classification of 1 to 5. And then another input data point is a preoperative functional status, which is defined as the functional status ability to perform ADLs the 30 days before surgery. And it's either totally independent, partially independent, or completely dependent. And then the procedure site, which is in broad categories: orthopedic, non-vascular, extremity versus, neurosurgical. You'll see the categories when you pull up the calculator. And once you input these data points, it will give you an estimated risk probability for this patient having an MI or cardiac arrest within intra-op and post 3 days. So this is the ACS NSQIP calculator website. This is what a lot of surgeons use when they're discussing with patients regarding the morbidity and mortality of their planned procedure. And oftentimes, anecdotally talking with surgeons, they use this in their M&M conferences in regards to the patient preoperative evaluation and post-op outcomes. This is more intensive in regards to the data points that are needed. In addition, this is very procedure specific to the point where they need the CPT code for the type of surgery or procedure that they're doing. And you do have to be handy with the EHR, actually have your EHR handy to be able to input all these data points. And it's literally, 20 data points that you're placing into this about your patient for this specific procedure. And then once you put those data points in, it will give you a risk estimate. If you actually Google risk calculator, ACS NSQIP risk calculator, you'll be able to find it on their website. So when you are able to put in these data points, it's quite a list of items to go through of outcomes that they look at. And so this is just the patient that I put in regards to the risk outcomes that came out for this patient. And so you can see here the outcomes that they're measuring for this, 75 to 84-year-old gentleman who had laparoscopic cholecystectomy with his type of risk factors. You see serious complications, any complications, pneumonia, cardiac complications, surgical site. And this is oftentimes what they provide the patient with in their discussions for surgery. So in general, the bottom line for cardiac risk, I would say for low risk procedures, cardiovascular testing is not indicated. For high risk procedures, we consider cardiovascular testing if it will change the outcome. For significant cardiovascular diseases that are acute, including valvular disease, severe arrhythmias, prior coronary stents, even things like hypertrophic cardiomyopathy, we generally consult our cardiology colleagues. And then there is the use of calculators. However, they're tools and not decision makers, and helps us discuss with the patient, the surgeon, anesthesiologist, and the care team in regards to thinking about the risk assessment for these patients. And then low risk does not mean no risk for our patients who have a low calculated risk. However, it is surgery and there's always risk associated with it. All right, so to move on to pulmonary risk. In general, for our pulmonary risk assessment, we do not need to get chest x-rays or PFTs for non-cardiac, non-intrathoracic surgeries. Understanding is important to have medical optimization of our pulmonary diseases, including COPD and asthma. And we can talk to our pulmonary colleagues in regards to difficulties or challenges if their patients are particularly complex. We do consider assessing for obstructive sleep apnea before surgery. And then there are actually a few risk assessment tools that we use and we educate our residents about. The Gupta post-op respiratory failure calculator is actually the same researchers who created the Gupta cardiac risk calculator. I think they flip-flop first and second authors. In addition, there's also the ARISCAT calculator, which is by Canet and colleagues, done in 2010. And this is another one where both of these calculators, you input data points and it provides you a risk assessment. So for the Gupta post-op respiratory failure calculator, this is the one we most frequently educate our residents on. It is also used using the same database as the American College of Surgeons database for the National Quality Improvement Project. It is defined as post-op respiratory failure is first 30 days after surgery. There's an unplanned intubation during surgery or post-op. The patient is re-intubated post-op after being extubated, or they require mechanical ventilation over 48 hours post-op. So what can post-op respiratory failure predict in regards to 30 days and long-term mortality? So when we are looking at the outcomes for all comers, 3.1 to 3.4% of post-op patients had respiratory failure. 26% of these patients pass away within 30 days. And these are similar rates between academic veterans hospitals and community hospitals. And honestly, there's been no decline in post-op respiratory failure over the last decade. So when you think back to the Gupta cardiac risk calculator, those patients had a 0.65% of all comers have a myocardial infarction or cardiac arrest, and a little over 60% of those patients passed away. But in post-op respiratory failure, there's a higher overall of all comers who have respiratory failure, and a little over a quarter of those patients pass away. So this is another screenshot. I took this from QXMD, and this is the Gupta post-op respiratory failure calculator. It has similar input points for your patients. So if you pick the procedure type, the ASA class 1 through 5, whether this is an emergency case, once again, functional status is an input point or data point for your patient. And then sepsis in regards to whether it's septic shock, SIRS criteria, and you'll see those listed out. And this will provide you with an estimated risk of post-op respiratory failure. We actually use this calculator more for our pulmonary risk assessment because it's actually not separated out in the ACS and SQIP risk calculator. So in general, the bottom line for pulmonary risk, no studies or imaging are needed for most procedures, non-cardiac, non-intrathoracic. Consider assessment and treatment of OSA and optimization of pulmonary diseases prior to surgery. And the recommendations that we make for these patients, if they're low or moderate risk category for pulmonary risk, we recommend early ambulation and lung expansion maneuvers. And if the patient, I would say if their risk is calculated to be above 3 to 4% and they're high risk, early ambulation, lung expansion, and consideration of extubating to CPAP in the first 24 to 48 hours of surgery would be something good to recommend. All right. So the next category would be VTE, venous thromboembolism risk and prevention. In general, low-risk surgeries, including minor surgery and mobile patients, we just recommend early ambulation. For moderate risk surgeries, which are most general surgeries, or high-risk surgeries, which include orthopedic surgery, major trauma, and spinal cord injury, we do recommend pharmacologic prophylaxis. And so in these higher risk surgeries, or higher risk VTE risks, in orthopedic surgeries, in particular hip fractures and hip replacements, there is extended prophylaxis up to 35 days after surgery, and then up to 28 days for patients with manual surgery for malignancy. These are the ones with extended prophylaxis, VTE risk prevention. So we can move to perioperative management of chronic anticoagulation. So when we're thinking about the risks and benefits of perioperative anticoagulation, what we're really trying to balance in these patients is the risk of bleeding from the surgery or the procedure, or the risk of a thromboembolic event for whatever reason why they're on the anticoagulation. This is a chart taken from the CHEST guidelines in 2012, which is specifically for the perioperative management of patients on warfarin. You'll see here, this is a chart we actually include in our trifold that we give our residents when they're on medicine consults and doing preoperative evaluations. You can see here in the column on the left is the thromboembolic risk that's divided out between high, moderate, or low. And in these middle columns, you'll actually see the reason for the patient being on warfarin, whether it's a mechanical heart valve, atrial fibrillation, or history of a VTE. And in this last column, you'll see the recommendations, whether or not the patient needs bridging anticoagulation, whether it be Lovenox or IV heparin. And in general, for all of these patients over the past 10 years, we've found that unless the patient is at high thromboembolic risk, they really do not need bridging Lovenox or IV heparin. If the patient does need bridging anticoagulation, we recommend we discontinue the Coumadin 5 days before surgery. This is where we get to the bottom part of this chart. And we can recommend low molecular weight heparin, and it's generally 1 mg per kg Q12. And the last dose is given 24 hours before surgery. If the patient does need to be on a heparin drip, we generally recommend they be off the heparin drip 4 to 6 hours before surgery. Now, when we get to the post-op assessment of Coumadin, bridging anticoagulation, if the patient's on warfarin, we restart Coumadin 12 to 24 hours after surgery if there is no bleeding. If it's a minor or low bleeding risk procedure, we can resume the Lovenox 24 hours after surgery. However, if the patient actually has major surgery or is at a high bleeding risk, so for example, some of those surgeries would be a hip replacement, hip fracture surgery, we do not restart therapeutic anticoagulation until 48 to 72 hours after surgery. However, in this time frame, there's a few days. If you're worried potentially you could start Lovenox at a prophylactic dose, understanding that there's not we should not start full dose anticoagulation until post-op day 2 to 3. I think a lot of us are more familiar or used to using over the past few years the DOACs, or direct oral anticoagulants, or novel anticoagulants. So actually, this is a study that came out by Dukitis. He's actually an international expert on perioperative management of anticoagulation. This came out in 2019. This is based on the recent studies of the Bridge trial and the Pause trial. And in general, DOACs do not need to be bridged with low molecular weight heparin or a heparin drip. So what you see here is a table taken from this study where they looked at apixaban, dabigatran, and rivaroxaban, and how to manage these DOACs around the time of surgery. So in general, you see here, if a patient has a low bleeding risk surgery, and these would be colonoscopies or hernia repairs, they would be considered low bleeding risk, and the patient would not take his apixaban or her apixaban the day of surgery or day -1. However, if it's a high bleeding risk procedure, they would not take the apixaban day -1 or day -2. That is the case for rivaroxaban as well. Dabigatran is a little bit different. Since the creatinine clearance, the renal function, if they're a little bit lower, then they actually have dabigatran hanging around longer. And so in renal insufficiency patients, the dabigatran is held longer for low bleeding risk procedures and for high bleeding risk procedures. And I also would put in here into this category elderly patients who are on dabigatran as well. And so for all of these patients, you see, post-op, if there's no significant bleeding, you can actually restart the apixaban, dabigatran, or rivaroxaban day +2, day +3 timeframe. All right, so to move on to the next category, we have delirium risk. And so in general, I would say a lot of the patients that we see who are age over 65, have cognitive, sensory, or functional impairment, has a psychotropic medication use, institutionalization, depression, or heavy comorbid disease burden. These patients are at increased risk of having delirium after surgery. We will look for etiology or a cause with the usual things as we do for delirium if a patient is admitted, looking at signs of infection, withdrawals of chronic medications, if they're hypoxic, have electrolyte abnormalities, or have pain or environmental changes, and medications such as anticholinergics or benzodiazepines. So I think in regards to therapy or treatment for delirium post-op period, we try to do initial behavioral management, which is try to help them with their sleep-wake cycle. If family members are available, to have them at bedside. And then if we need to, in regards to medications for agitated delirium, we can provide atypical antipsychotics, risperidone, olanzapine, or quetiapine if needed. And then on a very rare occasion, IV Haldol. So for perioperative diabetes management as our next topic, in general, I think we're aware that if the patient is on a basal long-acting dose of insulin, we provide half of the dose the night before or the AM of surgery. If they're also on short-acting insulin, we hold the short-acting insulin and put them on AccuChecks post-op, peri-op. And in regards to non-insulin medications, we do not give them the AM of surgery, and we consider restarting them post-op depending on the PO status or and monitoring their AccuChecks. There was the prior practice where people stopped their sulfonylureas or metformin multiple days before surgery. However, we actually, based on more recent studies in regards to improved wound healing and diabetes control after surgery, those patients can take those PO meds up until the day of surgery. In regards to perioperative medication management, there are a few medications we think about that have particular concerns around the time of surgery. So in regards to beta blockers, there was significant literature in this by the cardiology. In general, if the patient is on a beta blocker, continue them on the beta blocker in the perioperative period. However, if you're thinking about starting a beta blocker, we really try not to start the beta blockers within 48 hours of surgery, and preferably longer before surgery. If you need to start, the better. In statins, patients can remain on their statins around the time of surgery. And actually, there's some thought to decreasing the risk of postoperative atrial fibrillation, in addition to plaque stabilization when patients have peripheral artery disease surgery. For ACEs, ARBs, and diuretics, when talking with our anesthesia colleagues, when patients are on these medications, in particular the ACEs and ARBs, intraoperatively, they actually have a risk of dropping their blood pressures and difficulty with having their blood pressure recover despite pressor agents. And so if a patient is older or has renal insufficiency, I would recommend, we let our residents know to recommend to our patients to not take the ACE, ARB, or diuretic on the day of surgery, and to consider not taking them the day before surgery as well. And then in regards to starting them post-op, we can see what their renal function looks like post-op and what their volume status is. In regards to steroids like prednisone, if the patient is on 20 milligrams of steroids on a daily basis for many years, those patients most definitely need perioperative stress dose steroids. And then if they are on less than 5 milligrams of prednisone daily, those patients generally do not need stress dose steroids. In the frame of 5 to 20 milligrams, depending on how you feel your patient is stable on it, or if they've had a history of adrenal insufficiency around the time of surgery, those patients would likely benefit from a perioperative steroid pulse. Then I put here rheumatologic meds. A lot of our patients nowadays are on biologic agents. And so their American Society of Rheumatology does have their own guidelines in regards to rheumatologic meds and what we should do with them perioperatively. And then always reviewing the medication list. So I put an example here, abiraterone, I believe, is a secondary prostate cancer treatment. However, it does have actually action upon the adrenal glands. And so this is actually given with prednisone, and it's considered to be a suppressant in like steroids. And so those patients actually need to be on stress dose steroids around the time of surgery as well. I also list in here some special circumstances. So there's more recent data showing that patients who have a recent stroke within the past 9 months, if we have wiggle room in regards to surgery, those patients potentially we should recommend they consider holding off surgery, because those patients actually have a increased risk of myocardial events and cerebral vascular events. For patients with Parkinson's disease, these can have significant side effects in medication withdrawals. So a lot of times we'll need to take a closer look at those medications and contact our neuro colleagues. Our patients with myasthenia gravis, a lot of these medications can have anesthetic side effects. So most of the time, I've only seen a few patients with myasthenia who needed a pre-op, and most of the time I have to refresh myself on up to date to look at what those medications that we need to be worried about. In addition, things like hypertrophic cardiomyopathy, there are some considerations to in regards to volume status that we need to let our anesthesiologists know about. And then in our cirrhotic patients, there's actually a MELD score that can help us determine the risk of surgery, regardless of how risky the surgery is. But based on their MELD score, they have a 7-day and 30-day post-op outcome in regards to morbidity and mortality. All right, so we've done a whirlwind of risk assessment for a pre-op risk for cardiac, pulmonary, VTE, anticoagulation, delirium, diabetes, medication management, and then going through some special circumstances. So what we can do is get back to our case from before. If you remember, it's our 64-year-old ALS patient, ALS-like patient, and COPD. So what we'll do is I'll give you more information, and then we can think about the questions on the side here. Does this patient need any studies prior to surgery? What are our pre-op evaluation concerns? And number 2, what further recommendations do we have? So for our patient, his functional status has declined. He's needing more assistance with some ADLs. His neurology clinic notes state he has dysphonia, aspiration, and he's refused a PEG. So on our physical exam of the patient, his vital signs, he's got a bit of a temperature, 100.8. His blood pressure is 110/65. His heart rate is 110. He has a respiratory rate of 24 and oxygen saturation of 91% of room air. In his physical exam, in general, he's thin, speaks in whispers and short sentences, and he has a wet cough. On his neck, he has a C collar in place. Cardiovascular wise, you hear that he's tachycardic, but otherwise no murmurs, rubs, or gallops. On his lung exam, you hear diminished upper airway rhonchi, no wheezing. Abdominal exam is benign. His extremities, he appears to have decreased strength in bilateral upper and lower extremities. When you evaluate his labs, they're normal. And on the medications, he's on carbidopa, levodopa, 1 tablet 4 times a day, aspirin 81 milligrams a day, budesonide formoterol 2 inhalations daily, and on his EKG, he has sinus tach 110 beats per minute and no change from prior EKGs. So going back to our questions, does he need any surgery, studies prior to surgery? What are our preoperative evaluation concerns? And what further recommendations are needed for him? So I'll go back to the case information. And in this setting, I think what I would go through and do is potentially calculate his cardiac risk, his pulmonary risk, in addition to potentially worrying about his fever here with a somewhat low blood pressure, and he's hypoxic. He's also got some medications we need to worry about, the carbidopa, levodopa. And in general, he doesn't sound like he's super stable.
So Emily, it's smart data. Wouldn't you just kind of start with a sepsis evaluation?
Yes. Yes. So if we look at him, this patient, he is relatively, we're worried about him. You're right, Dr. Nadeau. He's got a fever, he's tachycardic, has hypoxia, but he also has a C1, C2 fracture. So when you talk with the neurosurgeons, I'm glad you really brought up that point. The neurosurgeons actually say they feel this is an emergent surgery because they're worried based on the fracture site, there's high risk of cord transection. And so that's why they're calling us to assess him for pre-op risk. And so we will try to do our best, but we also will make recommendations on the other medical issues that are going on. So you're exactly right. So in this setting, I think I would calculate a cardiac risk, calculate a pulmonary risk, and sort of address and discuss the sepsis issues, and then see what we can do from that then on. And so I have the answers here, if it's okay to share with everyone. And so in this setting, I would say, Dr. Nadeau, you brought up the fact that he may be sepsis or having issues. And so he has a wet cough and he's hypoxic. This would be appropriate for us to assess for a chest x-ray to see if honestly he has a pneumonia, potential and aspiration pneumonia. He is on inhalers, so he has this history of COPD asthma potentially. And then when we actually calculate his Gupta post-op respiratory failure risk on the QXMD calculator, if we put in the type of surgery, he's actually getting spine surgery. The ASA class is American Society of Anesthesiologists classification, and there is some subjectivity to this, and it's generally a scale of 1 to 5, 1 being a totally healthy patient, 5 being close to moribund. I would say he's an ASA 4. When you look at his history, he's already not fully independent, so I would call him a partially dependent functional status. And then I would categorize him as a preoperative SIRS. And so that actually gives you a risk score of 13.9% of having a postoperative respiratory failure event. And then when you input his data points for the Gupta perioperative cardiac risk, age, creatinine, ASA, partially dependent, and spine surgery, his cardiac risk assessment is over 1% as well, so 1.67%. And so it's pretty worrisome for this patient. However, the neurosurgeons are saying this patient really needs to have surgery. And so I think this is a real opportunity for us to have a discussion with the surgeons, the patients, the healthcare team, the anesthesiologists about the risks of surgery. And then when we think about further recommendations for him, it's a really good idea to get consultation with the neurologists regarding his long-term prognosis of his ALS-like disease. He has sort of been ignoring the recommendations of a neurologist in clinic where they were saying, hey, we think you need actually a PEG placement because you're aspirating. And so having the neurologist or ourselves sort of explore that. And then when we look at his medication lists, recommendations regarding carbidopa, levodopa, there are significant withdrawals if those patients aren't able to get these medications. And so we should restart these medications as soon as possible. If the patient is unable to take them or provide them with alternate routes. And since he's having spine surgery and he was on aspirin, the aspirin should be held as well. So this patient was actually a patient I took care of a few years back at the VA who was in this exact scenario. And so the resident and I saw this patient separately. And while we were together going through his pre-op risk assessment, we heard a code blue overhead. And this patient actually had a respiratory code blue where he had to get intubated fiber optically and then was subsequently transferred to the SICU for stabilization. And while he was in the SICU, we talked with our neurology colleagues, and the neurology colleagues said they weren't entirely sure what his disease was, but they felt the 2-year prognosis was very guarded in regards to long-term survival, and the 5-year prognosis was just dismal. And so when we talked with the patient, he was highly educated and his wife was highly educated as well. We explained everything that was going on and both of them wanted to push for surgery. He had the misunderstanding that since he wasn't coughing anymore as much, that actually his dysphagia was getting better. And so he didn't realize it was because he was losing his cough reflex from the ALS-like disease getting worse. And so when we talk with our anesthesia colleagues for this patient, we said, we're worried about his breathing, and they were very worried as well. And this patient has been recommended to get a PEG before surgery, and he refused multiple times. And so we said, based on his risk assessment, is this an opportunity for us to say, hey, this patient needs a trach and PEG before surgery? So when they actually talked with the patient and his family, they trached and pegged him, and he went to surgery, had his neck fracture fixed, and a few days later was actually doing physical therapy, walking with a walker, although with a lot of assistance, and eventually went into rehab for rehabilitation. And so that's why it can be sort of tough. I would say in this setting, I really tried not to put my ethical beliefs or, thoughts on what his prognosis would be, and sort of really tried to provide the objective data I could with the family and the surgical team and anesthesiologist to sort of help them make the best decision that they felt like was needed for him, for his life. All right, so then we actually have another case. Is there time to do this other case? All right, case 2. A 74-year-old man with medical problems of hypertension, paroxysmal atrial fibrillation on aspirin, hyperlipidemia, presenting for a pre-op eval for a right hip replacement the next month. He is active, however, his hip pain is limiting his activity over the past 3 months. He's able to walk for 9 holes of golf without any symptoms, but now is more limited due to pain and is driving his car during golf. He is vital signs afebrile, blood pressure 110/65, heart rate 80. His physical exam is grossly benign, and his labs are notable for a creatinine of 1.5. His medications are metoprolol 50 BID, lisinopril 10 daily, atorvastatin 40, aspirin 325. And his EKG is normal sinus, rate 90, and no change from prior EKGs. So when we think about the questions for him, does this patient require any additional cardiovascular testing prior to surgery? And what recommendations do we have for his medications? All right, so if we plug him into different calculators, if you plug him into the Micah Gupta risk calculator, and you place in there 74 years old, an ASA class of 3, he's totally independent, being an orthopedic procedure, his perioperative cardiac risk is 1.34%. We use sort of the arbitrary cutoff of 1% as being elevated risk. However, he's actually pretty functionally stable. He was actually able to play golf up until his hip pain. When we plug him into the RCRI, he actually has 0 risk factors, which means he has a 0.4 to 0.5% of a perioperative cardiac event. So based on this, we do not feel he needs any more additional cardiac studies to assess. And then the next question to answer is, what recommendations do we have for his medications? And we briefly went over this. So in regards to his metoprolol and his atorvastatin, since he's already on these medications, they should be continued in the perioperative period. And then we discussed previously, ACE, ARBs, diuretics, if they're elderly or have baseline renal insufficiency, it's good to hold the day of surgery and possibly the day before surgery. In regards to his aspirin, we should hold his aspirin. And then since he is having a hip replacement, to consider DVT prophylaxis up to 35 days post-op. All right. So hopefully we were able to cover the objectives today, identify the main components of our pre-operative evaluation, utilize the main components to perform a pre-op evaluation. And then, I'd like to just thank my prior mentors and current colleagues who have really helped us educate our residents on preoperative evaluation. And then, our residents are great, and hopefully they'll be able to take this and use this in the future. So I'm open to taking any questions.
Thank you so much. This is Marissa. I had a question just about, so I know you just mentioned on the Gupta score that a score above 1% was higher and more concerning, but then we don't necessarily need to do any evaluation. So is just putting in the Gupta showing that we put in the risk stratification? I mean, like, so your cutoff is 1%, but
Yes.
then.
Great question. So let me try to repeat the question. So should we put them into Gupta just to demonstrate the risk assessment potentially? Is that accurate?
Yeah, I guess because it doesn't necessarily dictate what I'm gonna do, right? It just shows what their risk is, and then if I deem based on their circumstances, then I can do further assessment.
Correct. And so I think that's a great question. I think most of the time we provide a sort of percentage estimation. I don't know how helpful it is overall, but I think a lot of times when we do a pre-op risk assessment, I'll actually provide a summary statement for whether it's the patient, the anesthesiologist, the surgery, or the healthcare team. I'll say, patient is going for hip replacement surgery with known coronary disease and elevated cardiac and pulmonary risk. However, all these medical conditions are stable and do not need preoperative risk. Patient is stable and should continue blah, 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 blah medications. So you're right. I think it's sort of a combination of things, and that's why we shouldn't hang our hat on these calculators and tools. And this 1% really is more arbitrary, as where they're saying, where ACC and AHA say that 1% or less, those patients are considered low cardiac risk, but over 1% based on a risk assessment, calculator assessment, is elevated risk. And that's where we go down to this algorithm with these different boxes. Honestly, if the patient, like the second case where he was 76, but had relatively good functional status prior to his hip hurting, even though his risk assessment was 1.67% or something like that, since his meds were good, he doesn't have other symptoms like heart failure or lower extremity edema, it is safe to say he can proceed to surgery. Does that make sense, Marissa?
Yeah, of course. Yeah, and I think it's just with our podiatry patients, we do it, I mean, every time they get admitted, right? And so it's just I think the overall understanding that's just a risk assessment, but then we have to put what that risk means, like for Gupta, that above 1% is saying that they're higher risk. And then same, I think, did you start off for the revised cardiac risk?
No, so it's the same thing. Revised cardiac
1%.
risk is just an additional calculator to use that, well, you don't even have to have, for the other ones, you have to input something into a calculator. But this one, you can just based on the risk predictors there. So right here. So if the patient has these predictors, then you can literally relate it to 0. This is the risk. If they have one of these, then this is the risk. And so I'm glad you bring up podiatry, because we get quite frequently asked by podiatry to provide risk assessment at the VA for these patients. And a lot of times, if it's a local surgery where they're not going under general anesthesia, they really don't need a risk assessment in the traditional sense. Most of these patients that we're providing risk assessment for are going under general anesthesia, which is considered, not low risk procedure. And so when we touch base with our podiatry colleagues at the VA, a lot of times what they're really looking for is medical stabilization, medical in regards to medications management of their, medical problems around the time of surgery. And sometimes they needed an H&P since they're not, they can't put in the H&Ps on their own. So when they ask for a pre-op risk assessment, most of the time they don't really need a pre-op risk assessment since it's peripheral surgery, not under general anesthesia. What they really want is, medications, medical diseases monitored Does that make sense?
Yes. Yeah, we do it a lot. We carry the podiatry patients for them to do all their H&Ps and
Yes.
everything on our service.
Yes.
Yes, definitely makes sense. Thank you so much.
Mhm.
Do you make any specific adjustments for consideration of outpatient versus inpatient setting for the duration perioperatively?
You mean if I'm seeing a patient in clinic and we're doing a pre-op assessment and whether or not they should be admitted after surgery?
Kind of, yeah. So if say I'm in the clinic setting and I get someone who comes in and they have a provider who's asking for perioperative risk stratification versus, the hospital where maybe the orthopedist is asking me to do that for someone who's going to be admitted for probably several days around that time period.
Mm-hmm. Yeah, so, if it's a particularly complex patient where we're pretty worried that the post-op course could be challenging to manage, I'll try and see if I can touch base with that surgeon to just sort of explain our concerns about the challenges peri-op, post-op. And I think a lot of times they could see that post-op wise, this patient may have issues and they'll themselves want to admit the patient. So what I've seen is for like patients who require a total knee replacement or a hip replacement, post-op wise, they will admit these patients for a few days, especially if they're on anticoagulation or they have diabetes and they need monitoring afterwards. I would say where I practice at the VA, they don't necessarily always call us post-op wise, but if we see these patients in our pre-op clinic, I'll actually recommend, hey, this is a patient that please feel free to consult the medicine consult team when they're out of the OR, and we would be happy to assist with these, the medical issues and the post-operative period. So I think there's some sense that you can help them through that time frame, especially if you're worried about the patient. Does that answer your question?
Yes, thank you.
Mm-hmm.
Emily, I had a question about the echoes on your flow diagram. It talks about echo in selected cases. So
Yes.
I mean, I'm thinking, if you hear something on the symptoms or if
Right. No.
exam, or if they maybe had a bad, like a really low ejection fraction in the past and you haven't had an echo in a while. So any other tips as far as who you think needs an echo?
Great. So great question when we're considering this box here. So based on the most recent guidelines, which is actually a little bit older now, 2014 ACC/AHA, understanding that this is coming from cardiologists, so they're going to say, echo more than not. If the patient has not had any changes, but does have a history of, aortic stenosis, and has had an echo within the past 2 years and is clinically stable, they say you don't need to repeat an echo. However, if you feel that the patient actually has new symptoms, or you feel like there's been a change in something, whether it's, he now has lower extremity edema or he's having more shortness of breath, then even if that patient has had, an echo within the past few years, it's probably worthwhile to consider getting another one and then sending them to have assessment with their cardiologist if they're being followed by cardiology. Yes. Now, so when we educate our residents, all our residents do a medicine consults rotation, and in that month they do all the pre-op risk assessments that we get called to do on both sides of the street. They also longitudinally in their PGY2 and PGY3 year have, just their PGY3 year, they go through IMC pre-op clinic. And then they do the risk assessments, pre-op risk assessments for their own personal patients. So we provide them a trifold card and then sort of going through the evaluation when they have that dedicated time on their third year rotation. And I didn't know if there's any questions in the chat. Okay, no questions in the chat.
I don't see anything else. Does anybody else have any other comments? Questions? Okay, I will actually send out the link for today so that we can give Dr. Wang some feedback. But thank you so much for joining us, everybody. And thank you, Dr. Wang, for going over the pre-op assessment.
No problem. I hope it was helpful.
Thank you.
All right.
Great talk,
Bye.
Thank you.
Yeah, no problem.